Good afternoon and welcome to Grand Rounds today. Please remember to fill out the attendance records, and also please remember to fill out the program evaluations if you would, and give us any ideas that you might have in regards to future topics or future speakers. Our speaker today is Dr. Rami Almokayyad. Dr. Almokayyad is board certified in internal medicine and endocrinology, and he is also certified in bone densitometry, and he is a certified neck ultrasonographer. He's a member of the Department of Endocrinology at McFarland Clinic, and he's here today to share some endocrinology pearls with us, so please join me in welcoming Dr. Almokayyad.
Thank you. Thank you, Steve, for the introduction, and thank you for everyone for coming here today. I'll be talking about general endocrinology today, and the theme or the layout of my talk is actually clinical vignettes. And we'll use these clinical vignettes to help us in having a discussion about different endocrine testing that we do, and to try to understand the idea behind it, and maybe it will translate to something that will be useful for your practice on a daily basis. There will be clinical vignettes followed by questions, and the questions are multiple choice questions, and we'll be using the audience response system. So please, everyone is encouraged to participate. They told me that the winner, or the one who will be answering the most questions right, will be winning a really good prize here. They're planning to give him a full night stay in the new hospital for free. So really it's encouraged there. So we'll start the talk with the first case. So this is a 45-year-old man who came to the office because of fatigue and low sex drive. He has type 2 diabetes, hypertension, dyslipidemia, taking medication for that, metformin, simvastatin, and lisinopril. And on exam, he was 300 pounds. His BMI was 37, and it was 4 p.m. in the afternoon. And you wanted to check him for hypogonadism. So you went ahead and checked the testosterone level. And the testosterone level was 200. And normal starts at 240 in that lab. So you're thinking about hypogonadism in this guy, but you check the testosterone at 4 p.m. So what would you do next after that? Would you start him on androgel, or did you start him on actually testosterone patch, which is androderm, or would you start him on testosterone shots, or would you repeat the morning testosterone level and maybe check a free testosterone? All right, 31 responses. I think that's good. Let's see. All right, so most people got the answer right. We'll repeat the morning testosterone. So the reason behind that is this curve. So this is the average testosterone for people, normal people, over a 24-hour period. And you can see that the testosterone level usually starts to rise overnight and gets highest in the morning when you wake up in the morning, and then goes about 50% lower in the afternoon, and even lower at the end of the day. So if you go ahead and check the testosterone in the afternoon, you'll get a falsely lower number. On the other hand, if you check it in the morning, you'll get actually the number that you need. Testosterone also fluctuates from day to day, similar to most of the steroid hormones. So even with one morning number that's low, you need to repeat that again a second time. So at least 2 morning numbers needed to be checked to check for actually hypogonadism. There was a good guidelines by the Endocrine Society that actually emphasized all these parts, and I encourage you, if you're really screening for hypogonadism, to read these guidelines. They're up to date. I think they're 2 or 3 years ago. So the first take-home message I want you to, when you screen for hypogonadism, you check for the testosterone in the morning, and at least repeat it twice. The other caveat with testosterone checking is total testosterone versus free testosterone. So usually testosterone is floating in the blood through 2 forms. One is freely floating in the blood, and that's actually the active form, which is called the free testosterone. But also there's the one that's bound to the sex hormone binding globulin and loosely bound to the albumin, and that's actually most of the chunk of the testosterone. The problem is the sex hormone binding globulin actually changes depending on the weight. So if you're having an extreme of weights, it will change. Obese patients will have lower sex hormone binding globulins, and if you do that, that will lead to making the testosterone look smaller, but actually the free testosterone is normal. On the other hand, people who are elderly will have actually a little bit higher sex hormone binding globulin. People who are underweight will have higher sex hormone binding globulin, and that will lead to higher testosterone level, but the free testosterone is normal. So the second take-home message is if you're having a patient who's falling in these extreme weights, I would suggest checking a free testosterone to be able to determine what the testosterone function is. Another thing I usually check, especially if I check it the first time and the first time was low in the morning, the second time I'll check the luteinizing hormone and prolactin to be able to identify what's causing the low testosterone. Now, all of us have been watching TV probably, or maybe me by myself, but you have watched the low T advertisement, and there's a lot of advertisement about low T, especially during the Super Bowl for some reason. And you can't, I think there's a lot of false advertisement there because they're just putting all the symptoms in the world, and if you just, that's one of the prototype of the questionnaire that they advertise for. If you're older than 30 and you're tired, you may have low T. If you're older than 30 and you're taking any medications, you might have low T. If you're older than 30 and you're not having enough money in the bank, you might have low T. So that's I think there's a lot of false advertisement, and that leads to a lot of checking because patients are asking for being checked for hypogonadism, and that's why it's important to check it early in the morning, because otherwise if you get a falsely lower one, they will have something in their brain that's saying, I have low T and I need to fix that. I thought I'll give you some update on what formulation of testosterone do we have right in the market, just because in the last probably 4 years, we have few new testosterone formulation that actually introduced. The older one, which is the androgel, that's the classical one, has been in the market for a long time. It used to be 1% in the past. They updated that to be a little bit more concentrated to make it more convenient for the patient, so less volume. So we have that. But the FDA was a little bit concerned about the cross-contamination that happens with the androgel. So there's a couple of formulations that were approved by the FDA recently to tackle that problem. One of them is the Fortesta, which is 2% testosterone, so it's actually more concentrated, so a smaller volume. It's applied to the finger, and you rub it to the inner thigh there. So you just expose one finger there to the testosterone. That leads to less cross-contamination. There's another one, which is the Axeron. That's the one that actually is applied through an applicator. So you put the gel in the applicator and then apply it under the armpits. And that's actually, there's zero cross-contamination from a hand standpoint. But of course, the expense is the problem here. Androderm has been in the market for a long time. They updated the dosage of that, so there's a 2 and 4 milligram dosage of the testosterone patch. There's no cross-contamination problem with that. The problem with that is it's a little bit abrasive, so patients have trouble with skin rash from that. They typically have to put it every night, and eventually you'll run out of space, so you don't have any space. All of the areas will be inflamed. Injectable forms, the testosterone cypionate and enanthinate has been in the market for a long time. These are given usually every 1 to 4 weeks, depending on how the dosage is. But there is a new testosterone formula, which is Avid, that was just approved, that's given every 10 weeks. And that's very convenient for the patients. The only downside of that, they had a lot of oil embolus happening from giving that shot. So they're asking, if you give it to the patient has to wait for an hour in the office to get sure that they don't have shortness of breath or any problems with respiratory problems, indicating some oil embolus. That made me a little bit concerned about it. I'm not sure I'll be using that. Testosterone pellets has been in the market for a long time. It's too invasive to put them in, and I think they're not that convenient, hard to retrieve them if they have trouble with that. So we're not using them that frequently. If you ask me which is better, testosterone gel versus, or transdermal testosterone versus injections, this graph will actually tell you the difference. So the difference is the gel will give you a steady number all the time. It's more physiologic. You apply it every day, so it simulates the normal production of testosterone. The shot will give you a really super physiological level the first couple of days, and then normal levels, and then low levels at the end of the period of the next shot. So it's not that physiologic. But $15 versus $300, some people prefers the $15. So it's really less expensive, the shots versus the gels. We'll move to the second case now. So this is a 25-year-old female who came to the office with a lump in the neck for 3 months. She doesn't have a family history of thyroid cancer and has no history of radiation exposure. And her exam shows a 2-centimeter thyroid nodule on the right lobe. So what would you do next? Would you send her for surgery and get the right lobe out? Or would you arrange for an ultrasound-guided biopsy of that nodule? Would you do an ultrasound first? Or would you check a TSH? All right, I think that's good. 39. All right. So there's a split there. So nobody wants to take her to surgery, which is a good thing. That's good. Nobody, some wants to do a biopsy, which I think all of them are reasonable, but where to start with? And I think that's the idea of that question is what to start with. And I think that goes to review the ATA, the American Thyroid Association guidelines about approaching thyroid nodules. And the first thing after you do the history and physical exam is to do the TSH. And that circle should be around the TSH, by the way, so didn't go there. But so the reason why you need to do the TSH, because your approach is a little bit different. So if you have a suppressed TSH, you want to get sure that this is not an autonomous functioning nodule by doing either radioactive iodine or technetium scan. And if it's actually a hyperfunctioning nodule, this does not need to be biopsied, because typically it's benign. On the other hand, if the TSH is normal or high, then you need to do an ultrasound to identify how many nodules you're talking about, and then possibly biopsy the nodule depending on the patient characteristics and the thyroid ultrasound finding there. So definitely a TSH is very important. I can tell you from my practice, I have many patients with thyroid nodules. They come to the office without they will have the ultrasound, they might have the scan, but without a TSH for some reason. So that's always missed. So it's very important to do that. So my third pearl probably is the presence of thyroid nodule. You need to do a TSH. If the TSH is normal, you arrange for an ultrasound. If that was suppressed, you arrange for radioiodine uptake and scan. Now, I thought I'll just review with you also when do we usually do a biopsy of the thyroid nodules. So two things you look at. First, looking at the patient characteristics. If the patient has a family history of thyroid cancer, if they have a history of radiation exposure, then that's a high-risk patient. And usually any nodule usually needs to be biopsied, typically more than 5 millimeters. On the other hand, if they have low risks, then you have to look at the ultrasound characteristics there and see how many nodules you're dealing with and what the characteristics are of the nodules. So if they're hypoechoic, usually it's 1 centimeter is the threshold to do a biopsy. If they're mixed complex nodules, then it goes up to 1.5 to 2 centimeters. And if they're spongiform, it's 2 centimeters. And thyroid cysts should not be really biopsied to rule out malignancy. We can drain them to help with the symptoms sometimes, but really does not need to be biopsied for that. All right, so moving to the third case. Another 25-year-old woman who came to the office because of weight loss, unintentional, having severe anxiety, palpitations. You examined her. She had tremors, her thyroid is enlarged, and you did some thyroid labs, and you did a TSH and free T4. Her TSH is suppressed, her free T4 is high. So she's thyrotoxic. And you're suspecting a disease there, either Graves' disease or thyroiditis, but you're not sure, and you want to differentiate that. So what's the most cost-effective next test to diagnose the underlying cause of the overactive thyroid there? Would you do a thyroid ultrasound? Or would you do a radioactive iodine uptake and scan? Or would you do a thyroid peroxidase antibody? Or would you check a thyroid-stimulating immunoglobulin? 2 responses are missing. I'm waiting for 40. All right, here we go. Oh, there's a lot of split here. So I'm asking about the cost-effective way of doing it. So the right answer is actually 4, which is the thyroid-stimulating immunoglobulin. Pretty sure everybody does all of them, all of the above, and that's not the answer here. But really, with this patient being young and having a diffuse enlarged thyroid, so you're concerned about either having really a subacute thyroiditis or if she has Graves' disease. And usually the thyroid-stimulating immunoglobulin is very sensitive and specific for Graves' disease, that if you check it, it will really tell you the answer there. Now, if it's negative, then that's a different story. You need to really do further testing. But if it's positive with a blood test, then actually you have the answer and you can really go ahead and do the treatment after that. And being cost-effective, the TSI costs about $73. On the other hand, the ultrasound costs about $232, and the uptake and scan is about $1,200. So really, sometimes you can skip the uptake and scan if the TSI is positive and the clinical scenarios goes with Graves' disease. You can go ahead and talk about the treatment. The uptake and scan needs to be done, though, if they decide to do radioactive iodine treatment, but really it doesn't help us in diagnosing if the TSI was positive. So just remember, TSI, quite frequently I see the TPO antibodies checked in people with hyperthyroidism. The problem with that, it doesn't tell us too much, because the TPO can be positive because of autoimmune processes. It can be either from subacute thyroiditis, it can be positive, and it can be negative in a big percentage of people. So it's very helpful in people with underactive thyroid to make the diagnosis of Hashimoto's disease, but not that helpful with the hyperthyroidism. I prefer with overactive thyroid to check a TSI to identify the cause of the overactive thyroid. Fourth case, 52-year-old man with history of type 2 diabetes, hypertension, and dyslipidemia. That's different than the other guy from the first one, by the way. Has accelerated weight gain. He gained about 60 pounds in 6 months without any changes in his diet or exercise. On exam, he had some round face, and he had some few old stria, and he had central obesity. And my question is, you're concerned about Cushing's. What would you do to screen for Cushing's syndrome? And I think that's an area of a lot of confusion, I think, regarding what to do with the cortisols. Do you check a morning plasma cortisol, an afternoon plasma cortisol? Do you give them a dexamethasone at night and check the morning cortisol? Or do you give them the dexamethasone in the morning and check the night cortisol level? All right, perfect. So most people got it right. It's 3. We do an overnight dexamethasone suppression test. And I'll go through that explanation for why we do that. So that's another steroid hormone that goes through the diurnal variation there in the levels. So the morning cortisol will be the highest that you'll get. Usually it's built up overnight, and then in the morning, that's the highest cortisol level that you'll get. The levels will get lower in the afternoon, even undetectable at night, and then goes higher in the morning. In people with Cushing's, they have cortisol high all the time. So if you try to do a morning cortisol to rule out Cushing's, you cannot really differentiate between normal and Cushing's, because both of them will have normal elevated cortisol. So you need to look at the cortisol in the afternoons. And the problem is there's a lot of variability with the levels. So the standard is to do an overnight 1 milligram dexamethasone suppression test. So with the 1 milligram overnight dexamethasone suppression test, you usually give the patient 1 milligram of dexamethasone orally at midnight, and then you ask them to go to the lab at 8 o'clock in the morning. And the timing is a little bit important with that. So if they screw the test, if they skip taking the dexamethasone and they go to the lab in the morning at 8 o'clock, that will make the levels look really high, and that's not really... So it's important to educate the patients about the timing and that they have to take the pill and they have to go to the lab at 8 o'clock in the morning. Normally, it should be less than 1.8 microgram per deciliter. There's a lot of caveats with that, though. Dexamethasone can be metabolized faster in some people and slower in other people, so that's one big caveat. The compliance is another problem that can happen. But in general, if it's more than 1.8, then that's suspicious for Cushing's, and probably further testing is needed. So my take-home message on that, remember, if you're concerned about Cushing's, you do a 1 milligram overnight dexamethasone suppression test, or you can refer them to endocrinology to do that. But don't do morning cortisol levels because they will be normal. Now, on the other hand, if you're looking for screening for, and let me go back to this slide, if you're screening for adrenal insufficiency, then morning cortisol is reasonable to do, because that's when you want to get the highest level of cortisol, so you check the morning cortisol. And you don't check the afternoon one, because that will be falsely lower. So it doesn't mean that they have adrenal insufficiency if their cortisol level is low in the afternoon, because that's normal. Other tests that we can use to screen for Cushing's, and all of them are actually as good as the overnight dexamethasone suppression test, is doing the 24-hour urine collection for cortisol. The problem with that, it's a little bit cumbersome for the patient to do. It needs a lot of arrangement for them to do, so it's not really the first line, but that's something that we usually use as a confirmatory after we do the 1 milligram dexamethasone suppression test. The other one that we don't use frequently, but it's actually, it should be really utilized more frequently, is the salivary cortisol, because the cortisol is actually bound to the cortisol binding globulin, and that does not reflect the free cortisol levels most of the time. However, the salivary cortisol reflects actually the free cortisol, the active cortisol. The problem with that is collecting the sample. So you usually give the patient some tubes, and they have to really wash their mouth really well, and then spit in the tubes and collect about 2.5 ml and then send it to lab the next morning. There's a lot of variability with the labs of that, so it's not really still standardized on that. We're trying to have better testing on that, because that really reflects the true free cortisol for that. All right. We're going through the 5th case, so if you have answered all of them right, hopefully you'll be answering this right and you'll be winning the prize here. So a 63-year-old woman who has type 2 diabetes for 10 years, and she's currently maximized on metformin, glipizide, and taking sitagliptin, which is Januvia. And she's trying to be compliant with diet and exercise. She follows the very common diet, which is the seafood diet. She sees the food and eats it. And her A1C is 8.1. And the question is, what would you do to improve her glycemic control without making her gain weight? Do you add basal insulin? Do you add short-acting insulin? Do you start her on TZD with Actos? Or would you start her on SGLT2 inhibitor? I was asking about SGL2, that's sodium glucose cotransporter 2 inhibitor. "13 people are still missing here. I'll wait. All right, nobody wants to continue that. Well, most of the people got the answer right. So that's a new novel medication that actually was approved recently, and a new class that we add to our artillery in combating diabetes. So the sodium glucose cotransporter 2 inhibitors. So you know that the glomerulus will filtrate the blood and filtrate the glucose to the tubules. And usually the glucose, most of it actually reabsorbed in the proximal tubule here. There's 2 types of glucose reabsorbing receptors there, or transporters, the SGLT2 and SGLT1. The SGLT2 is actually the predominant in the kidneys, and they're specific for the kidneys. The SGLT1 is present in the kidneys and present in the intestine as well. So if you inhibit the SGLT2, you'll inhibit 90% of the reabsorption of glucose from the tubule, So it goes to the urine without getting reabsorbed. So you'll filtrate the glucose, it goes through the urine, and you're not reabsorbing any of that. So that tackles diabetes in a different way than usually tackling either the incretins, which tackle the intestine, or tackling the insulin itself. So it's really insulin-independent mechanism. So it's similar to the diuretics in which they get rid of salt. We have glucouretic that take care of the glucose in the blood, and that will lead to lowering the blood sugars. So again, it's a really new way of looking at diabetes. And fortunately, we have two new medications that were approved just recently. The canagliflozin, which is the Invokana, and that comes in 100 and 300 milligram dose. And the dapagliflozin, which is the Farxiga, that comes in 5 and 10 milligram daily dose. And they're very efficacious in getting really the A1C down. If you can see, that's for the Farxiga. Monotherapy is comparable to just metformin, but if you combine it with metformin, it actually reduces A1C by about 2.1%, and that's for a baseline of A1C of 9.2. So if you get the A1C down by that, you'll get about almost within target there. So it's very efficacious in getting the A1C down. The average is you'll expect about 1% reduction in A1C as an average for everyone. Similar results were seen with the Invokana here. Because you're using this medication to lose about 300 to 400 calories from not reabsorbing all the glucose there, so you're losing about 300 to 400 calories in the urine every day. That will lead to weight loss. So that's another favorable effect of that medication. So they'll lose about 6 pounds on average. That's on the Farxiga study. On the Invokana, they put it as a percentage of their weight, so they'll lose about 3% of their weight if they use that medication, simply because they're just peeing out glucose, so they are not really reabsorbing that. And because you're getting some osmotic diuresis with that, so you'll have the blood pressure lowered because of that. Sometimes we have to adjust the blood pressure medication to tackle that. So it's about 5 millimeter mercury reduction in the systolic blood pressure there with the Farxiga. Similar was seen with the Invokana. Now the side effects. The biggest one is frequent urination. They will be going to the bathroom frequently, and they will notice that. It might be actually a good conditioning there, because when they eat a good carbohydrate meal, their blood sugar will go higher. They'll go to the bathroom after that. So hopefully that will prevent them from eating a big carbohydrate meal. A big one is volume depletion, and I usually encourage my patients to drink a lot of water to combat that. Hypoglycemia is very limited there, just because it does not really tackle the insulin part, but when they're taking other medication and you get the glucose lowered, it can lead to hypoglycemia. Electrolytes imbalance, and usually I'll check the electrolytes after a month of taking it, just because it can cause some hyponatremia, especially if they're taking diuretics. One common side effect is genitourinary infection. So yeast infections, urinary tract infections, especially in women, especially in women who had recurrent UTIs before starting it. That will increase it quite a bit. So the patients need to be educated about that, and really need to be let know if they have any symptoms of UTI to let you know. There is a slight increase in LDL, so that's something that you might need to monitor. The dapagliflozin, actually, this is the oldest one that was supposed to be approved first, but it was denied twice by the FDA because of the bladder cancer concern. So there was an increase in the incidence of bladder cancer on the group that they were taking dapagliflozin. Again, eventually they approved it because more studies did not really translate to increased number of bladder cancer. There was 4 bladder cancer patients on the medication group and 0 on the placebo group, and that's what raised the question there. The number is small, but again, that's something that I would not use it on a patient who had already bladder cancer or maybe family history of bladder cancer. And the canagliflozin has some interaction, so rifampin will reduce the medication efficaciousness, and digoxin will be increased by the canagliflozin use. So I want just to remind you about a new class of medication to treat type 2 diabetes. It does not cause weight gain and have a good effect on blood pressure, which is the SGLT2 inhibitors. So in summary, if you want to screen for hypogonadism, you do a morning testosterone level. And if the morning testosterone level is low, I'll repeat probably another time in the morning. And probably I'll check an LH, a prolactin level, and free testosterone in selected patients. If you have a thyroid nodule, you need to do a TSH first. And if the TSH is suppressed, and radioiodine uptake and scan need to be done rather than ultrasound. But if the TSH is normal or high, then you need probably to do an ultrasound and possibly biopsying that nodule. I want you to remember TSI and hyperthyroidism. That's useful lab that can help you in knowing what the cause of the hyperthyroidism. And remember that an 1 milligram overnight dexamethasone suppression test is one of the first lines that I would use to screen for Cushing's syndrome. And we have a new medication that tackles the glucose in the urine. We call them the SGLT2, Invokana, and Farxiga, or canagliflozin and dapagliflozin. And that will conclude my talk, and I will be happy to answer any questions. Yes, Larry.
Great job. One of the best talks ever.
Thank you.
Rami, in your mind, would the SGLT2 inhibitors be the next step after metformin?
Probably. Well, it's really hard to justify that right now.
Oh, okay.
Just because I think the incretins will be and that's really a good question, because it's really hard to know what's the best next step after metformin. And I think I'll tailor it to the patient. The problem with the insurance right now, nobody's approving that as a second line.
Okay,
so
that's what I was wondering.
Almost you cannot use it as a second line right now. But eventually it will be a flexibility between incretins, sulfonylureas, and SGLT2.
Okay, thank you.
Larry kind of hinted at my question, which is, what is an SGLT2 going to set me back, cost-wise?
Oh,
which are they?
Well, because of that, for now, because there are new medications, for most commercial insurance, actually, you don't pay a lot with the coupons that they have. After that, it will be very, very expensive. But for now, we're getting advantage of the coupons that we can use. It's about $10 per month or something like that.
I was wondering what your thoughts are about the Affirm genetic test if the patient has an equivocal thyroid nodule aspiration.
Well, it's a good tool to help so the question is about genetic testing on the biopsies to be able to differentiate certain mutations that increase the risk of thyroid cancers. It can be used in certain circumstances. My experience so far, we have not used it quite a bit right now, so it's not really something that we use as a standard thing. It's a tool that we use in indeterminate nodules. So people who have indeterminate nodules, which is about 20% of the nodules are indeterminate, they can use that genetic testing. The problem is the sensitivity and specificity. So if it's not that good, if it's positive, then that's something you'll take surgery, but if it's negative, it's really hard to justify just watching it, and probably you eventually have surgery on that. The other problem is on other institutions, the experience from other institutions, that you have to repeat the biopsy a few times to get actually adequate sample to be able to run that genetic testing. So that's another limiting factor for using it. But I think it's something that's evolving, and eventually you'll be using that more frequently, in which it will be the standard of care. If you have an indeterminate nodule, that you'll do that genetic testing to determine if surgery is indicated on that or not. But it's not there yet. It's really way in the early steps of that.
Do you have a screening test for early Addison's disease?
So usually the standard test to diagnose adrenal insufficiency is doing the 250 microgram ACTH stimulation test. However, in people who have autoimmune diseases that are at risk of having autoimmune adrenal disease, you can check actually the antibody against 21 alpha hydroxylase antibody. So that's usually specific for Addison's disease, and you can check for that.
Thank you for your excellent talk. I'm sure you deal on a daily basis with people who are overweight. So 2 questions on that. One is, are the SGLT2 inhibitors being marketed for that? And secondly, what do you think is the single most effective thing you found in your practice for weight loss?
All right. Well, that's a loaded question. That's a big question, I guess. So it's not advertised for weight loss. The SGLT2 cannot be used for weight loss for now. They're trying to advertise or trying to study incretins, which are the Victoza and Bydureon and Byetta, trying to use them outside diabetes for weight loss, but they're not using them yet. They're under studies for that. If I know the answer of your second question, probably I'll not be here. So, so I don't think I have the answer for that.
What are your thoughts on the role of selenium supplementation in patients with hypothyroidism?
In preventing what? In preventing hypothyroidism?
Because the selenium is used for the thyroid enzymes.
So the only thing that really scientifically studied is using selenium in postpartum thyroiditis. So that's the only probably scientific evidence that it might prevent recurrent postpartum thyroiditis. So I might offer it for patients who had like 2 episodes of postpartum thyroiditis. That's something that they can consider. I don't think it can prevent hypothyroidism from Hashimoto's. I don't think there's any evidence behind that. And it does not prevent hyperthyroidism.
Thank you.
So a couple of questions on the cortisol testing, Rami. In the hospital, do you like recommend the cortisol? I mean, sometimes we do it because they're like septic or something. They're hypertensive or something. We do the.
I think it's very hard.
Cortisol still indicated in that.
So testing for cortisols in the hospital, that's a very, very hard question. Just because the patients usually they're sick, you expect the cortisols to be high, but it's really hard to know how much high they will go, and it's not the ideal situation to diagnose Cushing's in the hospital. However, for adrenal insufficiency, definitely that's something different. So if there's any suspicion about that, then I'll check probably. I do a ACTH stimulation test and start them on hydrocortisone, and then in the outpatient I'll test them. But for Cushing's, I would probably try to avoid testing them in the hospital and do it as an outpatient, because it's really hard to know how things are regarding stress and physiological increase in the cortisol in the hospital.
The second question, sometimes when I do the 1 milligram low-dose dexamethasone test, the patient forgets to take the tablet before night or something, and then they just go to the lab and get the cortisol level. Is there any level where we can still suspect this is, like, let's say 25 or 30, then we can...
No, all of them will, any high level does not indicate Cushing's at all. Okay. So that's normal. And that's very common for them to forget the 1 milligram dose at night. So it's very important to emphasize, because sometimes we'll get like 25. It's like, I have Cushing's, but really they're on. They just forgot to take the pill there, and emphasizing that is very important. All right, well, thank you for having me here for the talk, and have a wonderful afternoon.